Welcome everyone to our webinar, A Team Approach to De-prescribing and Preventing Medication-Related Falls, facilitated by the Fall Prevention Community of Practice. My name is Mariel Ang, and I am the Project Coordinator at the Ontario Neurotrauma Foundation. ONF supports the Fall Prevention Community of Practice and its online platform called Loop. Loop is a place where fall prevention practitioners connect. Visit us at www.fallsloop.com. Marguerite Thomas also joins us on the line. Marguerite is the liaison for the Fall Prevention Community of Practice. She will be assisting with facilitating questions in the chat box today. Before we begin, I'm going to give you a quick rundown on the Level 3 meeting system. This webinar technology consists of two parts. The audio is provided through a telephone conference line, and the visuals are provided through a web platform. The phone number for the conference line and the link to the web platform were sent to you by email after you registered for the webinar through Level 3. If you have any questions about the technology at any time during this presentation, please type them into the chat box on the left-hand side of your screen. Alternatively, you can email me at mariel@onf.org. That's mariel@onf.org, and I'll work with you to resolve technical issues as soon as possible. If you have topic-related questions during the presentation, please type them into the chat box. During the Q&A, questions will be read aloud to the group. If you would prefer to ask your question over the phone, we will provide the instructions to unmute your line during the Q&A. The webinar is being recorded, and a YouTube link will be sent to all participants in about 1 week along with the presentation slides. I would now like to introduce our presenter, Pam Howell. Pam Howell is a clinical pharmacist working for over 15 years with geriatric clients and clients with complex chronic conditions at Bruyere Continuing Care in Ottawa. Her role with the Bruyere De-prescribing research team has focused on knowledge translation and community engagement efforts to highlight the role of de-prescribing as part of good prescribing. She is looking forward to sharing her medication knowledge and patient experiences in de-prescribing to better help you manage your patients' medications effectively as they get older. For more information on the De-prescribing Guidelines Research Initiative, visit their website, www.deprescribing.org. And so without further ado, I will let Pam Howell take it away. Pam, just give me 1 moment as I unmute you from the line. Hi, Pam.
Hi, Mariel. How are you?
Good. How are you?
Good, thanks. So thank you very much for that great introduction, and thank you to everyone who is joining us today. I don't know how everyone's doing out in that blustery, wintry weather, but I know we're snow deep in about 4.5 feet of it. So thank you for coming, and thank you for taking time out of your day. So I wanted to kind of bring forward that throughout my discussion, in the next couple of minutes, if people want to feel free to kind of type in where they're from, what your professional background is, or what part of the healthcare sector you work in. I'm going to try to keep an eye on that in the hopes that I can bring a few tidbits, in that might be able to, include you as well, just out of interest. So a team approach to de-prescribing and preventing medication-related falls is the focus of today's presentation. As Mariel had mentioned, I've had a lot of experience now with patient care and with the de-prescribing team as far as meeting people and discussing medication-related issues. And the one thing that's really come to light every time is that everyone has a story, whether it's someone telling me about their mother that's been on too many medications, or a healthcare provider that's said, you know what, we tried de-prescribing this patient and it was amazing to see the difference in how they were functioning. And so it really brings to light the fact that there's an appetite for de-prescribing out in the healthcare world, and that there really is a need for it. Even from my own experience, about a few years ago when I was working in geriatric rehab, we had a patient who came in 55 different medications, and was just very non-responding. The family were concerned that, this was really an end-of-life situation. And what I learned was that with a great team approach and with a great focus with the team, we were able to get him down from 55 pills a day to 27, which still sounds like quite a bit, but he was able to walk out of our geriatric rehab program, and the one thing he said to me was, "You have nothing without your mind." And it really struck me that, there needs to be more done. And so when this opportunity with the De-prescribing team came about, I thought it was pretty fortuitous to be able to kind of bring these stories to light and help people, help others as far as medications and better medication management.
Hi, Pam. Can you just try to speak a little bit louder? We're having some people have their volumes at max.
Oh, sorry about that. That's usually not my problem. So, Marielle, how does that sound?
It's a little bit better.
A little better?
Hold, the phone a little bit closer to your mouth, perhaps.
Perfect. How's that?
That's a little bit better for me.
Okay. So as far as objectives are concerned, I'm going to try highlighting some key points about polypharmacy that relate to increased falls risk. I'm going to try to present the current de-prescribing guidelines research. And so these kinds of things will also highlight what's been going on recently with all of the work that's been going on. I'm going to encourage participants to think about their role in medication management and how it fits within the healthcare team. I'm going to try to push your envelope a little bit and make you think outside of the box, that it's not just a prescriber or pharmacist problem, but definitely something that everyone can participate in. And as well, I'm going to try to engage all of you to reflect on how de-prescribing could be managed within your expertise and in your care setting by using the available tools and resources. So some of the cases that I'm going to present in the last few slides, even though they're kind of based in certain situations, I'm hoping you can kind of think to yourself, how would it apply if that person came to me? So just because they may be a patient out in the community, it could be that same story of a person coming into acute care or a long-term care facility. So hopefully we can kind of expand that kind of discussion. So before we start, I want to make sure that everyone realizes that medications still have a role. They still treat symptoms, they still slow the progression of disease, and they still reduce the risk of complications from diseases. So it's not to say that every medication is bad. But what we can say is that sometimes at some point there gets to be a point where the use of more medications than are needed or for which harm outweighs that benefit. So when does that scale outweigh the benefits and the risk? And that's when polypharmacy comes along. So you may not necessarily need to be on many medications, but if they aren't the right ones for you, then that could be considered polypharmacy. And you're looking at increasing the risk for things like drug interactions and adverse reactions. For our group here, falls and fractures, functional and cognitive decline, which impacts the patient's quality of life. You're looking at non-adherence, hospitalizations, and higher healthcare costs. At particular risk is our elderly individuals, and the reason for that is because they handle and respond to drugs differently. They're often more frail, and they're not typically represented in the research that says that you should start medications. And how big is this problem? Quite large when you think about the fact that 2/3 of Canadian seniors are prescribed at least 5 prescription medications. Sometimes there's more patients now with 10 or more, and it's very rare that I see patients that aren't on at least 5. $419 million is spent on potentially inappropriate medications. So it's not even on good medications that our healthcare system is spending money on. It's more medications that are risky or that could be causing more harm than good. And unfortunately, $1.4 billion are in incremental healthcare expenditures. So things like healthcare or hospital admissions because of falls or fractures and any other kind of side effects that may come along with those medications and interactions. Who's at most risk? people with multiple chronic conditions because of the fact that they end up being on multiple more medications. Women tend to be prescribed more risky medications and are more at risk of having side effects with those medications. And unfortunately, as people age, we do notice that they are prescribed more medications as well. Each year in Canada, 1 in 200 seniors are hospitalized due to the harmful effects of their medications. So that patient population is definitely one that, if they're coming across your doorstep, are ones that you really want to keep an eye out for. And unfortunately, they're also hospitalized 5 times more often. As we get older, all of our body organs and functions do become more sensitive to drug effects. So the brain becomes more sensitive to side effects. Our body tends to keep medications in it longer, so the effects of those medications tend to accumulate over time. Our liver and kidneys do not process medications as efficiently as they did when we were younger, and our body contains less water, so that way more medications become more concentrated. And so what level was normal for us as a younger patient, unfortunately may end up having more of a concentrated effect later on. So which medications increase the risk for falls? You can see that there are quite a few that are indicated, and the two that I've circled here, the benzodiazepines or sleeping pills and the antipsychotics, are definitely ones that our de-prescribing guidelines have focused on. And funny enough, a lot of the times medications that increase your risk for falls are also associated with decreasing cognition. And just to kind of give you an aside little note, some innocuous medications you may want to keep on your radar as well, where they do actually promote falls or may increase your risk for fractures. So things like hypoglycemic medications that are treating blood sugars. If you have a hypoglycemic reaction, the risk of falling with that is much higher. Or patients that may be on chronic proton pump inhibitors, they are associated with increasing fractures if you do end up falling. So there's even medications not on this list that still need to be on your radar. And we also know that the more number of medications that you're on increases your risk all the way up to 2.5 times higher if you're on 8 or more medications. When you think about the fact that most seniors are on at least 5, you already have a 2 to 2.5 times higher risk. So if we know so much, why does polypharmacy still happen? And unfortunately, more medications are available than ever before for treating certain conditions, which then tends to overprescribe in certain situations. People are living longer and acquiring more diseases, so that means you're treating more multiple comorbidities. A lot of the times, guidelines for medical diseases or chronic conditions tell you when to prescribe or when to start medications, but unfortunately don't give you the information of when to stop them. Increased hospital admissions means that there's many prescribers throughout the transitions of care, so medication reconciliation becomes more difficult. There's more people, as far as cooks in the kitchen, prescribing medications. There's a fear of rocking the boat with many prescribers. If I wasn't the one that prescribed it, then I don't feel comfortable de-prescribing it. If there is a specialist that's involved, well, they are the ones that take care of that, so I don't want to touch it. Or if it's not, if it's not broken, then why fix it now? There's also that idea of the culture of prescribing. And what I mean by this is pretty much looked at in our next slide. You can see that, the change in prescribing culture and patient attitudes is half of the battle. We have a long-standing history of the idea that if I have a symptom or a problem, just give me a drug and it'll fix it. And that's not only just on the healthcare provider side, but also the patients coming into the office saying, I have a problem, and expecting that a medication will be prescribed for them, whether it's actually appropriate or not, or whether there's even other alternatives. There's a lot of challenges and enablers in the literature that's been found. Prescribers may not be aware of polypharmacy as a problem. There's a lack of confidence in de-prescribing, so I don't know how to do it. Not having the time, and I think that's where the collaborative approach can really, really help. Being influenced by treatment guidelines, so like I mentioned, we know when to start things but not when to stop. And a lot of the times, though, de-prescribing, if raised by the patient, may actually be more likely to happen. So that could definitely enable things a little bit more. And if there are ways to examine the ongoing need for medication and ways to reduce that burden to help the prescriber, they're more enabled to do so. With the patient side, because it's not just the prescribers that sometimes say, I don't know how to do it, it's also the patients. And I think all of us have seen the fact that patients do have their own ideas and also sometimes their own fears about what's happening with medications. A vast majority of them are willing to stop a medication if it was suggested by the prescriber. They have a lot of influences as far as the media, what they've seen from friends or talked to with family. They may be fearful of de-prescribing, so what will happen if I get rid of it? But a lot of the times if you support them by knowing that there's a process, that there are people that are going to be helping them, then I think that's one of those ways that we can help promote de-prescribing and look at better medication management. So this is where the De-prescribing project kind of came in, and Dr. Barb Farrell with the De-prescribing Guidelines research team really has led the work here, and it's been based out of her experiences in the Geriatric Day Hospital here in Ottawa, where she keeps seeing many patients coming through on more and more medications, and a lot of the focus has been on the fact that we would love to get rid of de-prescribe, but we just don't know how to. And, who is it safe in doing, and who can we do it in safely? And so the concept of de-prescribing was kind of born. And the actual definition is the planned and supervised process of dose reduction or stopping of medication that may be causing harm or no longer be of benefit. The goal of de-prescribing is to reduce medication burden and harm while maintaining or improving quality of life. And I think when you look at the planned and supervised, that's where everyone has a role in playing it, whether you are a pharmacist, whether you're a nurse, whether you're a physiotherapist. All of us, hopefully, as we work through this presentation, can think about where can we fit into this process. Ultimately, we're trying to really promote that de-prescribing is still a part of good prescribing. We're not giving up on patients. We're not trying to say that all medications are bad, but I think it's always worthwhile revisiting what is this medication doing for me? What is it promoting, and is it really helping or harming me? So it's backing off even when doses are too high, or stopping medications that are no longer needed. And this slide here really does tell you that look at what is that balance. At certain points in everyone's life for the patient, their values and goals may be different based on whether they're 40 years old or whether they're 85 years old. And half of the process is making sure that you're looking at what is important to that patient. And when the risks of those medications starts outweighing the benefits, then that's when it's really time to look at what do we need to do. So the research guidelines team has really come up with 5 different evidence-based guidelines and algorithms that bring more confidence to the healthcare providers about saying which patients can we look at de-prescribing certain medications in, and which ones are safe to do so and how. And so we've come up with 5 different algorithms, one for benzodiazepines or sleeping medications like lorazepam or oxazepam, antipsychotics, so things like risperidone, haloperidol, proton pump inhibitors, which would be your Pantaloc or pantoprazoles, so cholinesterase inhibitors, and antihyperglycemics. And all of those can be found in our website, which I've included here. We've also been doing a lot of community group and engaging work with healthcare providers at conferences, at presentations, and working with other organizations to try to get the message out about de-prescribing. And we're also working on research to try to look at how can we get more community engagement in de-prescribing, how does this look in community pharmacy and also in the long-term care sector. So you can see that de-prescribing isn't just in one spot. We're trying to focus on the fact that it's a bigger picture. As far as the guidelines are concerned, when you go onto our website, you're going to notice that we do have tools on there that help prescribers and healthcare providers and patients see what they can do to help with de-prescribing. So all of our algorithms are based out of the same kind of format, where they kind of stepwise you through a choose-your-own kind of adventure idea, where you're looking at which patients are suitable, how would we do it, and which patients are not suitable for it. And the back pages of those algorithms always do try to include things about side effects, how to maybe engage the patients, what kind of non-pharmacological options are in there. And I think this back page for healthcare providers that maybe are not directly involved with prescribing might actually be the ones to focus or be able to consult as far as how can they help in these non-pharmacological options, how can they help with monitoring in these kinds of situations, and how can they help with engaging patients. And as well, engaging that patient who may be interested in de-prescribing, we also include tools that help with explaining what de-prescribing is, why we're looking at it, and the rationale. So that's all great, but I'm not a pharmacist or a doctor. So that technically sometimes is the response I get from healthcare providers that are not directly involved. And what I've noticed is that there's a lot of people or stakeholders involved in playing a role in improving medication management, anywhere from policymakers to support staff like PSWs and volunteers. And the reason for this is because all of us have contact with that patient or that caregiver at some point or another. And they really are the ones that are driving the success of de-prescribing. And so the more we can make sure that we support those patients in any way that we can, the more successful a de-prescribing plan can be. So as a pharmacist, I'm going to put on my pharmacist hat now. There's a lot of steps in the de-prescribing process that I go through when I'm thinking about de-prescribing. And the main component to start with is always a medication history. The better history you can get from a patient as far as why was it started, does it seem to be helping, what's the rationale for it, the better you can kind of help identify the potentially inappropriate medications, those ones that may be more eligible for de-prescribing, and how to prioritize those medications for de-prescribing. A lot of the times, too, that may also help me decide who I could bring in to help with medication management as far as developing a plan for tapering or monitoring. So if a lot of the times the patient is telling me, they're having dizziness related to the narcotics that they are on, would there be an opportunity for me to kind of consult with the physiotherapist and say, listen, we're going to try de-prescribing, but can you keep an eye on things as far as does the pain rebound back, or are we doing it too fast, or are there other options to help with pain management? And so developing that plan for tapering and monitoring can really be a collaborative process as far as who's involved with monitoring, how often and should it be done, who else can help decide how fast or how slow to do it, so whether there's specialists involved. And the monitoring and support can really help even the prescriber feel more comfortable about knowing that the team is coming back with good documentation and robust symptom reporting if the patient maybe isn't able to do that for us. So as far as little things that we can do, Medication reviews are definitely involved with medications that might be causing the problem as far as identifying that. Are the medications working well? And are the medications beneficial? And so a lot of the questions that I usually ask are, can this symptom be caused by a drug? So even yourself, when you're doing your assessments, whether you're a nurse, whether you're a physiotherapist, patients are always reporting symptoms of concern, whether it is dizziness when they're getting up, whether it is a dry mouth, whether it's the fact that they can't see straight. A lot of the times we're always looking at trying to implement other options because of our expertise, but what I'm hoping to impart on you is taking that step back and saying, could this be one of their medication side effects that is implicated in this? And, is there maybe a role for looking at that too? And who can I ask and who could be involved? Because a lot of the times patients sometimes may tell one healthcare provider something because at that moment they remember it, but maybe they might not remember telling me. And so that's why that team approach or that, constant communication about what you've learned and what you've heard really can make a difference. There are screening criteria out there that, just in case people haven't heard of them, the Beers criteria is definitely one way of identifying potentially inappropriate medications, as well as the start-stop. The anticholinergic burden is a way of kind of determining whether medications with certain side effects can be contributing to falls, and the higher the burden, the more risk there is for affecting your cognition, affecting your balance, affecting sedation. So a lot of the examples of medications that they bring to light to avoid are benzodiazepines, tricyclic antidepressants, antipsychotics, and digoxin. And then this is just a little slide to kind of show you the thought process that most pharmacists will hopefully go through as far as identification. And when you get the chance, what I'm hoping is that you may, kind of go through it and say, oh, this is a way I could kind of, put my expertise in there if a de-prescribing plan is coming in, or if the pharmacist is talking to me about something, then maybe this is where I could help them out. So what does applying all of this information look like in real life? And this is kind of where we're getting into the cases here. So hopefully everyone can start putting their thinking hats on. And we're going to start with case number 1, which is a tapering of a benzodiazepine. And both cases right now are actually going to look at benzodiazepines, but like I had said, this could be any kind of medication that you're looking at, and it could be any kind of patient that's coming through your door, whether you're in a long-term care facility or out in the community. So our little lady is 77 years old. She's had falls, pain, constipation, cognition, and polypharmacy. You can see her past medical history there includes cardiovascular disease, hypertension, dementia, fibromyalgia, hypothyroidism. She's been noted to have a loss of independence, so now she needs help daily with washing, dressing, and medications, and she's being referred to long-term care. And she's wheelchair-bound, heavily sedated, and interviewing and assessment is difficult. She's had near falls attempting to self-transfer and could not stand unsupported. And her creatinine clearance, so that's her kidney function, is quite low at 30 mils per minute, which means that she's also at risk of not being able to process medications very well. And here's her long medication list. The one that I've highlighted, just because of the fact that we will be looking at benzodiazepines, is her oxazepam 15 milligrams QHS. But in retrospect, there are multiple other medications that could be affecting her cognition and her function. And one of those could be the amitriptyline. You could look at the cyclobenzaprine. There's multiple different ones that if you put them in with the Beers criteria or the start-stop may actually be bringing up red flags. So it's one of those things where the medication history and getting a good input from the patient can really make a difference. And how you can see is that there's that interplay between the medications. When we had mentioned that the risk of drug interactions, the additional side effects or anticholinergic load can really start accumulating in a patient and can contribute to those symptoms that you see about falls, about decreased cognition, constipation, because all of them do not, they don't just stay in their own little sector in a patient's body. They all interact, they all interplay, and it's kind of like that trickle effect or a prescribing cascades where you can kind of, just see that everything is interconnected and can then contribute to multiple different kinds of side effects. So we're going to start with our little first poll question as far as what would you do? So you can see that she's on multiple different medications, and we talked about, what kind of different medications she could be on. So I'm going to say that if she was presented, in your care, what would be the first thing that you think you might want to try to do? So if everybody wants to try to put in a few things. Give you a few more seconds there. And we're going to do a 3, 2, 1. So everyone's kind of putting their things in. Right now, tapering the oxazepam is winning. And there are still a few other people that are saying, stop the amitriptyline or pick a different drug to de-prescribe. Leaving everything as is, I would hope not, given the fact that the patient is coming in with certain concerns, and as far as being referred to you, and I think there is still an opportunity to be able to do something, with engaging the patient and seeing what's important to them. So you're really hoping to kind of engage that patient and see where we can kind of go with it. You could have picked anything, I think, as far as whether the oxazepam is the first one you want to start with or is the stopping of the amitriptyline. You could have picked a different drug to de-prescribe. She's on a long list. So this is kind of a multiple choice, not a right or wrong answer question. But I think prioritizing things as best as you can at that point based on what the patient's telling you and what you think is the best one that you can pick is really the way to go. So there's really not a massive wrong answer, except I would hope that people will feel comfortable in at least starting that conversation and not leaving everything as is. So making the recommendations, for sure, I think identifying that the patient is having a problem and that we need to do something about it is that first step. Asking yourself about those drugs that might be contributing to that problem, so that's where you can kind of look at those Beers criteria and the start-stop. The suggested approaches to reducing or stopping that drug. So this is where the algorithms can kind of fit in as far as telling you how fast, what the patient, is looking like in front of you, what do they tell you is important to them, and also looking at what you're including with monitoring and follow-up with that patient. So this is where you want to say to yourself, well, if the patient is using it to help her sleep, then obviously the sleep isn't, the sleep may rebound. So who can we talk to about making sure that she's getting the right non-pharmacological options and making sure that they are maybe getting some exercise during the day so that they're more sleepy at night? Are they, do they need more daytime interactions to be able to not have that nap? So getting the volunteer services in, what kind of people can tell you whether she's more engaged during the day, so then that way you know that you're having a bit more success. And I think thinking about goals in the elderly and engaging them in that conversation can help prioritize which medications maybe you need to focus on first. If they are telling you that, no, I'm too scared to get to de-prescribe that benzodiazepine at this point. When you're looking at her medication list, well, then are there others that maybe she may feel more comfortable? You're trying to let them know that we're trying to improve quality of life, so the physical functioning, so you want them more active. What's their psychological functioning? So can we improve cognition? Are we going to hopefully manage their depression or anxiety better with other options? If social functioning is really important to them, then maybe this is a way of, opening up that door in that conversation to say that, we want you to be more alert for your activities during the day. And just that overall health and well-being aspect of the fact that sometimes de-prescribing medications can actually make you feel better. Why benzodiazepines sometimes is a big class of medications that are a big concern is because of the fact that we know that their use is quite common in adults and that it's quite expensive. The guidance for their use varies. Existing guidelines suggest that benzodiazepines should be used in the short term, but yet we seem to find that patients are on them for years and years and years and sometimes have no idea why. A lot of the recommendations coming out now are telling us to avoid benzodiazepines altogether in older persons, and that studies have shown that there's a detected loss of effect even in the benzodiazepines about 28 days after you start them. So that whole concept of I can't sleep without my benzodiazepine may actually be more in patients' mind than it is actually truly a good effect. And then we also know that benzodiazepines aren't harmless. Chronic benzodiazepine use can lead to physical and psychological dependence, and we know that they are associated with increased risk of falls, motor vehicle accidents, memory problems, and it got to the point where there have been even countries that have looked at taking away people's licenses based on the fact that they are taking benzodiazepines, so they've gone that far. So with our patient, you can see that knowing why the patient is on that benzodiazepine is the first step. And when we know that they're on what they're taking it for, can then decide on how fast and how slow we can de-prescribe it. But even though these are recommendations, there's always a way of changing things around depending on what the patient is telling you. And I think that's the biggest component, is making sure that you're listening to what the patient is telling you. How attached are they to the medication that you're thinking about de-prescribing, and how fast do they feel comfortable doing it? Having a bigger support system from other healthcare providers can maybe make that de-prescribing process feel more comfortable as well. So do they know who they can come to if de-prescribing is not working, or who can they come to if de-prescribing is working? As well, having the support of healthcare providers saying, oh my goodness, Mrs. So-and-so, last week your balance was really bad, but now that we've been, tapering your benzodiazepine, I've noticed that you've really improved. Have you noticed that improvement? So that encouragement from other healthcare providers, saying the same kind of information really does help that process as well as far as the supports. And that's kind of where the engagement of that patient in the back really comes along, and as well as encouraging patients to and healthcare providers about offering other alternatives to sleep. Physical activity obviously is a better way of engaging that sleep-wake cycle than would be a medication. Are there other healthcare providers as far as social workers or behavioral management therapists that can help with relaxation techniques and just talking through the things that might be aggravating the underlying condition? And getting the conversation started with the patient, sometimes they need time to think about it, and so giving them the patient pamphlets or the ability to kind of think through why we're bringing up this medication issue can also plant that seed and make sure that they're comfortable with the idea. So here's another question I wanted to ask everybody to kind of keep everybody in the loop. Which healthcare provider would not need to consider medication side effects in their assessment of this patient? So we'll see if what anyone thinks. Oh, that's great. We have a very good group. So everyone seems to be listening to my points. So it's totally true. I don't think that there's anyone in this list that could not be thinking about medication side effects. So even if you're going through your assessments, the physiotherapist, when you're looking at medications that could be contributing to falls, highlighting those medications to the other healthcare providers because you've noticed a problem with their balance. The occupational therapist, when you're looking at how are they functioning, they're really sedated during the day while I was going through my assessment. What kind of medications could be contributing to that? The speech language pathologist, I kind of threw that one in there for a bit of a loop. But even though the benzodiazepines may not be a medication that they would highlight, when you saw something called amitriptyline on her list, that actually has anticholinergic side effects which can be quite drying. So if that patient is coming, onto your service and reporting that, I'm really having a hard time swallowing, my mouth is really dry, it's difficult to eat, one of the medications could be the amitriptyline. And so, I think medication side effects, even in those kinds of situations, is still good to know about those red flags and what medications you might want to keep on your radar to let other people know that, the patient's reporting this symptom to me. So back to our patient. So we know that she's taking the oxazepam for anxiety and sleep, including the amitriptyline. So before tapering the oxazepam, we kind of need to make sure that there is that better approach to managing her anxiety. So are there certain referrals that you could be making to other specialists or behavior management teams? And what is your expertise to be able to kind of contribute to that? So can you offer them other opportunities as far as, like we had mentioned, ways of relaxation techniques? And what kind of non-drug options can you offer? And monitoring and de-prescribing. So that's really where that collaborative process can come into play. It happens with the patient, the family, and all the healthcare staff involved with their care. Whether it's feedback towards the patient saying things are improving, whether it's the patient giving feedback to different healthcare staff or healthcare providers as far as improvements or challenges, and also making sure that everyone is aware of what's the next plan. That they are saying that things are going well, so we're going to keep going, or wait a minute, things aren't going well, so we're actually going to change our plan of attack a little bit. Knowing what should be monitored and when. So depending on the medication that's being de-prescribed, I think it's important for everyone in the healthcare team to know, okay, well, what is my role to play? How often should I be monitoring it? Communicate why the drug is being stopped. And the reason why this is important is not just for the actual prescriber, but also for the team to be able to keep that consistent messaging with that patient. So when the patient may say, I'm having a bit of a challenge, it's easier for the team to say, we realize that sometimes there can be a few stumbling blocks, but we think it's important to keep that end of, that end goal in mind because, we want to improve your function. involving your colleagues who could offer non-pharmacological alternatives. So the only way you can do that is knowing what your colleagues do for you. And so part of this whole presentation too is me hoping that I can inspire you to say, you know, what does the physiotherapist do if you don't know yet? What does the social worker offer that could help? You know, take them out for coffee. Have that conversation. You know, figure out who you have in your community that you could be consulting or that you could be using as your go-to person. And documenting your plan and progress for that patient is imperative for the other care team members to make sure that they stay in the loop with what's been going on. So the patient outcome for this one, so we reduced them from 27 to 17. And you can see that she actually improved as far as her social interactions. She resumed a lot of her old hobbies. She came back to the geriatric day hospital, as Barb mentions, and was just a totally different person. And I think this is one of the good stories that you can kind of see comes out of the impact with de-prescribing and how many things could be improved. So case number 2, we'll try to go through this one a little quicker just to be able to still have time for questions. But I just wanted to let you know that, this is another, little old lady that's coming to you in your Falls program. She's not exactly sure why she's meeting you, but her daughter, who has come with her, is more concerned about all the falls that her mom has been having over the last 4 months. Upon further discussion about the falls, she tries to downplay them, but you're able to find out that she had a fall about 4 months ago after she tripped on a rug. At that time, she started having more pain, but reports any x-rays done by her family doctor were normal. Since then, she's had 2 more falls, usually in the morning when she changes positions quickly, with the last about a week ago, and she feels more and more dizzy and foggy in her mind. Her legs are also more swollen and feel very heavy when she moves. So I'm assuming that this is probably a typical patient for a lot of people out in the community, and even in inpatient when they're talking to patients that are falling. Her medication list really isn't that long. Only 6 of them. So, or only 6, I guess, in retrospect to what I usually see. But what I do want to point out is that the more you talk to her, the more you find out there's quite a bit of a trickle effect. Before all of her falls, she was on aspirin, amlodipine, and lorazepam, which hopefully will bring a red flag for you as far as the lorazepam is concerned. She had her first fall, which increased her pain. So she decided to start taking over-the-counter ibuprofen to help with that pain. And as you can see, ibuprofen can increase stomach upset, which then caused her to start taking omeprazole, which is a stomach protectant, and then also increased her blood pressure, which meant that the amlodipine was increased about 2 weeks ago, and then also can increase leg swelling. And unfortunately, the longer you're on omeprazole, the more risk there is for decreased B12 absorption, which then started her on the vitamin B12. And the longer that you're on omeprazole, the increased risk of chronic use can increase the risk for fractures. Increasing amlodipine can also increase the risk for postural hypotension and falls risk, and can also increase the leg swelling. So even on a short list or in comparison to a lot of people, you can still get quite a few different medication side effects and can actually start that trickle effect. So what drug do you think you'd want to start that de-prescribing conversation about first? Okay, so there's a bit of a split, but a lot of people are picking the ibuprofen, and then there are the group of us that are picking that lorazepam. And so I think both are actually appropriate to start the conversation with. And I think really a lot of it tends to depend on what that patient is telling you and what she's going to decide upon. There are those of us who might have said, oh, I think that lorazepam is the first one because of our previous conversation with our case number 1. And that's great because of the fact that we know that she's been using it for insomnia and that it was previously started because of her husband passing away about 7 years ago. So it sounds appropriate at this point. But when you bring it up with her, she's looking at you like this. And that technically sometimes is the face that I sometimes get when I even bring up the benzodiazepine de-prescribing. But it doesn't mean that you don't want to start that conversation about de-prescribing. And I think that's the one thing I want to hit to home to everyone is that you are going to sometimes hit those roadblocks, but it doesn't mean that you can't at least start that conversation. And I think that collaborative care and caregiver experience is that, as much as we know stuff, the patient knows them. And so you're trying to meet in the middle and making sure that you're aware of what's important to them. And you're trying to make sure that you know about the patient barriers, that they may not have that understanding, but if you give them the tools and the power to know about the fact that this is an appropriate idea or that there are going to be options if the symptoms return or that they're involved with the process, then their involvement and engagement in the success of de-prescribing is much higher. And this little slide can kind of go through as far as how do you introduce those ideas and how do you start that discussion, because that's always the hardest part. And the reason why I think we really need to be advocates, whether you are a pharmacist or not, is because a lot of the times you know your patients in their own home environment and know how to navigate the healthcare system. So advocating for your clients, to educate them and empower them where you can, to reach out where possible to maybe the family physician when you are identifying the concerns. So if you're out in the community, how can you make sure that you connect with that family prescriber a little bit more to let them know about what's happening? And as well, knowing your healthcare team. So like I talked about, who is out there for you to be able to consult or reach out to, knowing about what your community providers can offer to help that patient a little bit more if they're in those kind of starting stages. Food for thought, know what motivates your patient. So they may not know what's going on. They may not be really into it right now in the beginning. But I think sometimes when you bring to light what the side effects could be and why you're concerned, they may at least have that ability to process it and to think about it. Planting that seed, so offering information sheets, rebooking another appointment. It's actually kind of funny. I always laughed with one of my physicians that a lot of the times I would start the benzodiazepine conversation with a person and they would look at me like I had 3 eyes, and then she would go in about half an hour later and they'd be like, yes, doctor, I think you're absolutely right. And so it just sometimes takes that time. Engaging the other family members and healthcare staff to have the same message. So the more and more patients hear the same message, the more and more they're going to start realizing that maybe we're onto something. Be transparent about the process. So de-prescribing is trial and error. The same picture doesn't always look the same for every patient. So sometimes you may have to go slower for tapering. You may be able to go faster with others. You may have to offer other alternatives to make sure that they're supported through the process. And building on successes. So like we had mentioned in this case, maybe the lorazepam isn't the best one to start with, but as others had identified, that ibuprofen might be the first one to go. And then if they've really realized that, we have some success with that, then the lorazepam might be the next one. And then trying to prevent that the problem in the future. The prescribing problems sometimes happen with the fact that patients don't feel empowered to be able to say, ask those questions, setting expectations with drug therapy. So why am I on it? How much longer do I need to be on it? When are we going to reassess it? And ensuring that other healthcare providers are kept up to date. So if there is specialists involved, how do we engage them to make sure that they have the same message or are on board with our de-prescribing plan? And making sure that the patients feel encouraged to ask questions. So you can see that there's a picture there about the 5 questions about your medications to ask that you can find on ISMP. That's a really good one as far as, when do I need to ask about it, and giving that patient the idea of, what do I need to ask, because you don't know what you don't know. And so until you know, then you're really left in the dark. And so other helpful resources that I've kind of put on here are other websites. So ours is the deprescribing.org website that you can find a lot of the algorithms and patient information pamphlets on. The Canadian De-prescribing Network has a lot of good information for patient-driven and healthcare provider things on general de-prescribing. Choosing Wisely Canada is another one that has great toolkits as far as antipsychotics or PPI de-prescribing. And then, like I had mentioned, the ISMP website has that 5-question list that is usually quite useful with patients as well. And so I guess what I want to leave everyone with is to try to think about what your story is. What has engaged you? Why have you really thought that this is a good initiative for you to keep in mind? Because I think it really does portray that everyone has a role to play. And so what I'm hoping is that everyone's inspired to kind of take this back to where they work and think about it, and and join in on any kind of medication management initiative that might be happening. So thank you very much, and I think that's about it for now. My acknowledgement slides is there, but I'm very happy to try to address any questions in the last 5 minutes that we might have there, Marielle.
Amazing. Thank you so much, Pam, for such a great presentation. We do have quite a few questions, so I'll try to get through them. Bina Katari has asked, I have a patient who is being weaned off of TCA, unfortunately is having issues with sleep even though mizipine has been added. Any advice?
So that's always a hard one with de-prescribing is, when is it good, when is it not? Sometimes it may just be the fact that you've got the patient on less at this point, and you may just have to hold steady. You may end up having to just do a really slow taper. If they've been on it for this many years, it may require that little slower, monthly taper versus a longer one. It's really hard to try to promote switching to a different agent because a lot of the times the ones that you switch to have the same kind of side effect concerns. And so it really is difficult to say what is good in a patient at that stage.
Great, thank you, Pam. Second question, you mentioned the culture of prescribing. Wondering if some primary care practitioners are being bullied or coerced into prescribing to their patients. Do you have a comment on that?
That's a very good question, and it comes up from both the kind of engagement opportunities that I've had when I've gone to presentations or to conferences or talked to healthcare providers at different booths. And it really is a 2-part kind of education. So, we get it from the patients that say, prescribers, when I go into the office, they just give me a medication. And then at the same time, we get the prescribers saying that, patients come in, and when I bring up de-prescribing, they're looking at me, as if I'm giving up on them. And so the hard part is that it's quite easy to just give a prescription, and it's quite difficult to invest the time and the effort into those non-pharmacological options. And so I think knowing who can provide that support to send patients to, as far as your specialists or your other healthcare team members, will hopefully maybe make that transition a little bit easier. And I think that's why we're trying to really engage all components and all stakeholders. When I had brought up that one slide that had everybody there, so it's definitely a bigger problem than just one group in particular, and that's why there are so many groups out there. When I brought up the slide as well about different organizations and websites that are really trying to focus on all factors all at once.
Great, thank you, Pam. Another question that I will try to paraphrase because it's a little bit detailed, but one of our participants has just started working in the inpatients for a long-term care geriatric center, and their responsibility is to review charts. They're doing their best to follow guidelines, in particular use of antipsychotics in elderly with dementia. However, a physician who's working there for some time isn't comfortable with the recommendations or with changing medications, and they indicate that the patients are stable, eat and drink, and sleeps well, and that's the ultimate goal. So it forces our participants to reevaluate their role as a pharmacist in this kind of setting. Do you have any thoughts?
So it really, when I speak with physicians and pharmacists, the rapport and the relationship between the healthcare providers, can really make a difference as far as de-prescribing initiatives. So whether it's a matter of are you able to kind of sit down and meet with certain healthcare providers? So whether it's sitting down and meeting with that physician and having a good conversation about your role and why you think in certain patients it's important, or kind of making your case a little bit. Other times it might just be, okay, well, if maybe this isn't the real initiative, or if this isn't the initiative we can start with, is there lower hanging fruit that we can start with that might make that physician feel more comfortable with taking on something a little bit bigger? So whether it's just a matter of, okay, well, let's look at, reducing blood pressure medications because patients are falling too much and their blood pressures are too low. It could also be maybe encouraging other healthcare staff in that monitoring process and being engaged with the de-prescribing process as well. So if they believe that tapering antipsychotics will help, then they too will contribute to the monitoring process in making sure that there aren't any kind of rebound or relapse symptoms. Or you may just pick one person that you really truly don't think is going to make a difference, gain some success with that, and go from there. So you'd end up having more of an art than it is a science with de-prescribing, especially with people that are not that engaged. And building on maybe baby successes first instead of, tackling a massive big problem. So sometimes those are little things that can work. So hopefully that might help tweak a little bit of, being creative in those kinds of situations.
Great. Thank you so much, Pam. And just a comment from one of our participants, and I believe this is when you were going through the case study number 2, okay. But they have indicated that they would not recommend a cane with that Berg score. Just trying to see if I can pull up.
Oh, was that case number 1?
Case number 2, I believe, is when this came in. I can see your missing back.
It might have been, what happened with our patient there? Let me see if I can find that slide there, Marielle.
I think it was, they were both trying to change slides at the same time.
And I'll be honest with you, that very well could be the case, whether guidelines have changed as well. And I can't comment as far as what was, it's not my expertise as far as what kind of walking aids would be appropriate at that point. And so I can't make a massive comment there.
Oh, they just Leah's just responded, 31/56 Berg.
So I think it happened. Oh, I'm going to apologize there. I'm going to have to go back quite a bit, I think.
Yep, you can use the scroll bar to look through slides a little bit faster if that helps.
Sorry.
But in the meantime, just being conscious of time here, I will.
So I'll be honest with you there. That very well could be the case, and my apologies for not being able to make too much of a comment on that one, but that case presentation was definitely someone from a few years ago. So like I had said, whether things have changed in the last little while, or it would have depended on the therapist and the patient at that point too. So there could be those kinds of issues at that point. So I can't make total comments as far as whether it was appropriate or not appropriate.
All right. And that's fine. And if you want to get in touch with the person who asked that question, we can definitely put you to
that would be great.
Yeah.
And I can kind of take that back a little bit too.
Great. One last question before we go, because I know we're over time, but I want to make sure that everyone gets their questions answered. So one participant has asked, we have many residents coming in with high doses of calcium and vitamin D, but they are no longer walking. Do you have any study of the benefit of calcium when no longer weight-bearing or absorption rate after age 80?
So I don't have anything in particular that I can provide right now, but I would be more than happy to kind of see if there's anything as far as my colleagues or anything further with that. I know Marielle Marguerite usually does a little bit of a search as well. Is that right?
Yeah, we can both on Loop. We can actually do a search, or we can even start a discussion about it after this webinar. So that would be,
so maybe we can keep that conversation going, and maybe I'll learn a little bit more too. So.
Yeah, for sure. Okay. Yeah, that's a great idea. I love that. I love that idea, and I will definitely follow up with you about it. So just being conscious of time, I know some people are probably logging off now. It's 5 past, but I would just like to give a huge thank you to Pam Howell for taking her time during this crazy weather to provide this webinar presentation. I think everybody really enjoyed it and hopefully learned a lot from your wealth of experience in the area. For more information about the Fall Prevention Community of Practice, please visit Loop at www.fallsloop.com. We'll try to continue the conversation after this webinar. And just so everyone knows, we've launched a new online community of practice this year for children's fall prevention called Loop Junior. So if you have a passionate interest in childhood fall prevention, please join us at www.jr.fallsloop.com. Please don't close your window just yet. Wait until you've been redirected to the next screen where a brief evaluation survey will launch in your browser. We always appreciate your feedback so that we can continue to offer high-quality webinars. Thank you all very much, and stay safe in this treacherous weather. See you next time.